Bismillahirrahmanirrahim. Assalamu alaikum everyone. Quote of the day: You were born to win, but to be a winner, you must plan to win, prepare to win, and expect to win. Today, the topic of my presentation is basic financing models for healthcare system, and I am presenting it under supervision of my professor, Dr. Sair Afzal. Learning outlines: healthcare financing models, Beveridge model, Bismarck model, out-of-pocket model, national health insurance model, and recent updates, MCQs in the end. Learning outcomes: by the end of this presentation, participants would be able to describe different types of healthcare financing models, their application, along with the differences among them. Now, what is healthcare financing? It refers to how financial resources are used to ensure that the health system can adequately cover the collective health needs of every person. It is a foundational component that impacts the entire health system's performance, including the delivery, accessibility of primary healthcare. Core functions of healthcare finance can involve revenue raising, pooling of funds, and the purchasing of services. Now, these are the four models of healthcare system, financing system. First is we will discuss about Beveridge model, then Bismarck model, out-of-pocket model, and national health insurance model. The common principles of all models are choice, quality, cost, and coverage. The Beveridge model, it was named after William Beveridge, a social reformer. Healthcare is financed by the government through tax collection in this model. Many healthcare service agencies are owned by government and some private providers get fees from government. The main countries where this model is working is Britain, New Zealand, and Spain. Cuba is the example of extreme application of Beveridge approach. The characteristic features of this model are medical treatment is a public service. Providers can be government employees. Low cost because of the control of government over cost. It is also known as a single payer model because the sole payer is government in this model. Healthcare is provided and financed by the government through tax payments, and there are no medical bills to be paid by the public. The main concept behind this model is that healthcare is a human right, not a privilege. Government ownership and operation of healthcare, national government responsibility for delivery of equitable and efficient healthcare, full access to all regardless of ability to pay. Primary care physician is gatekeeper to the rest of the system. Now, as a whole, Beveridge model countries spend a lower percentage of gross domestic product on health care than any other nation. Why? Because the Beveridge model is tax-based and not insurance-based, the governments of those countries have great incentive to emphasize on preventive care. So the countries where this model is working tend to have excellent public health programs. The good in this model is primary care contributes to better outcomes for society, increased use of preventive services, fewer hospitalizations, reduction in overall cost, less use of emergency departments. The bad in Beveridge model is the welfare state values that call for a high level of social service also means higher taxes. The emphasis on efficiency often results in less choice for patients, and the broad service offerings tend to concentrate in urban areas. And doctors receive free education, have little administrative burden, and are most never issued for malpractice. They are also salaried and earn less than their American counterparts. So this is a grammatic representation of this model that the people are paying taxes and then government is the sole payer where rules and private or government provider provide health services to the public. Now, then comes the Bismarck model. It is named for Prussian Chancellor Otto von Bismarck, who invented the welfare state as part of the unification of Germany in 19th century. Compulsory funding from employee and employer contributions. That is, it is funded by payroll deduction. Management through sickness funds. Benefit package for all members, fully or partially covered. And the countries where this model is working is France, Germany, Belgium, Japan, Switzerland, and Netherlands. Now, it is used as an insurance model. The other name for this model is insurance model. Usually financed by the employers, and employers are responsible for funding by payroll deductions, and it doesn't provide universal health coverage. It just requires employment for health insurance, aging population, and the imbalance between retirees and employers to occur in this model. The characteristic features of this model is that providers and payers are private. Private insurance plans financed jointly by employers and employees through payroll deduction. The plans cover everyone and do not make a profit. Tight regulation of medical services and fees. The strengths of this model are more resources in the system, less dependence on budget negotiation, high redistribution dimensions. And weaknesses are possible exclusion of the poor, negative economic impact on payroll contributions, complex and expensive to manage, poor coverage of chronic disease in preventive care, and it is not aimed at universal coverage as Beveridge model was doing. Now, again, this is a diagrammatic representation where we can see that the workers are contributing, an employer and employer contribute to the sickness funds, and then government along with private providers, they are providing healthcare services to the public. Then comes the out-of-pocket model. It is the most common model in less developed areas. Patients may pay for their procedures out of pocket. The reality is that the wealthy get professional medical care and the poor don't unless they can somehow produce enough money to pay for it. So healthcare is still driven by income. Users' fees are paid directly to the public health facilities. Co-payments made by members of a health insurance scheme, which reimburses only a portion of the cost of a health service paid by the members. So these are the form of out-of-pocket payment. Out-of-pocket payments are also made to private providers by individuals not covered by any form of health insurance. So the countries using this model are India, China, some African regions, and South America. The characteristic features are that only the rich get medical care while the poor stay sick or die. And most medical care is paid by the patient, that is out of pocket. No insurance, no government plan, no organized system for payment, no pooling of risk, access limited. And in US, this is the model faced by large number of uninsured people. Then comes the national health insurance model. It blends different aspects of both the Beveridge model and the Bismarck model. The government acts as the single payer for medical procedures and providers are private, as in Bismarck model. Universal insurance that does not make a profit or deny claims. The potential for long waiting list and delays in treatment occur in this model. So here are the characteristic features that providers are private. National insurance collects monthly premiums and pay medical bills. Plans tend to be cheaper and much simpler administratively than private insurance. It can control costs by limiting the medical services they will pay for, making patients waited to be treated. And the countries using this are Taiwan, Korea, Turkey, and the classic national health insurance system is found in Canada. So here we can see that the public is paying insurance premium, then these are the supply, the private or government provider that are providing healthcare services to the people. Now, so in a nutshell, we can differentiate these four models, that the Beveridge model, which is used in UK, New Zealand, Spain, healthcare is delivered and paid for by the government. So government is the only sole payer in this model. Then Bismarck model, it is used in France, Belgium, Netherlands, and Japan. Funding for insurance is shared between employers and employees. And then comes the national health insurance model, which is used in Canada, Taiwan, and South Korea. All citizens pay into the healthcare system where the government is the sole payer. Then comes the out-of-pocket model. It is used in poor nations without a nationwide health system, such as the rural areas of Africa, India, and China. Here, the poor cannot afford healthcare and they do not get it. So they just stay sick or die, but the rich buy the care they need. Now, these are the main differences among these four models. In Beveridge model, Universal coverage is provided, which is funded by general taxes, government operated facilities, private physicians, limited private insurance in private facilities, global healthcare budget caps cost, significant access issues for non-emergent and non-primary care. Bismarck model, health insurance is mandatory. So that's why its another name is insurance model. Individuals select a private non-profit health plan funded by payroll taxes, care provided by private facilities and physicians, regulation and global pricing schedules, control cost, moderate access issues for non-emergent and non-primary care. Then single payer, this is also the another name for national health insurance model. Actually, the Burbage model and national health insurance model both are also referred to as single payer model, because in this the government is the sole payer. So the national health insurance model is that government funded health coverage, care provided by private facilities and providers, moderate penetration of private insurance, global healthcare budget cap cost, significant access issues for non-emergent and non-primary care. And this national health insurance model is the mixture of these two models, Burbage model and Bismarck model. Then the four comes out-of-pocket model. It is used by roughly 80% of countries, typically lack social and economic infrastructure to systemize care. All care paid for individual, not third-party funding. There is no third-party funding in this model. Generally, only the upper classes can access modern care. Public or charitable care options may exist but have significant access and quality issues. Recent updates. It is an editorial titled as a new healthcare model for Pakistan. According to it, healthcare in Pakistan is financed and provided by public, philanthropy, and private sectors. Current healthcare delivery systems largely provide tertiary care with very little focus on prevention. The public sector health delivery system comprises a district-based health system developed on the principles of primary healthcare. Private sector provides healthcare to over 60%, while 30% constitute public sector of the healthcare delivery in the country. The remaining 10% are other types of provider, including local NGOs and philanthropy. The share of private sector in total health expenditure is 65%, philanthropy sector is 20%, public sector share is 50%. Public sector includes healthcare provided by the social security institutions and by the state and parastatal organization. Almost 90% of private health expenditure is household out-of-pocket payment. For the purpose of reaching out to the most deserving areas and a need-based approach, we recommend an integration of public, private, and philanthropy sector investment in healthcare in Pakistan. So we propose following steps for integrated health system to improve its efficiency and quality. A health need assessment analysis and area variation in the health care needs, a GS mapping of all types of health facilities to identify services deficient areas, a legislation to regulate private sector investment, including a need-based criteria for private investment in health sector, a mechanism to discourage further investments in tertiary care, teaching hospitals in private public sector in 10 big cities, integration of healthcare delivery among private, philanthropy, and public sector, national health vision, provincial health policy documents with integration of health services into a new model with a higher priority of preventive health. Now, this is another article, inclusive policies for health financing towards universal health coverage in Pakistan, direct or indirect access. The purpose of this article that the unresolved crisis scenario in the prolonged COVID-19 pandemic increased social inequalities, mainly affecting the most vulnerable groups to access health services. The data in Pakistan show that the health coverage benefits less than half of the population. A weak health system forces households to finance their health with out-of-pocket expenses. Therefore, it is a pending task to guarantee universal health coverage and design sustainable and inclusive policies to finance and provide health service. So the aim of the study is to offer a unique solution for health financing to Pakistan. Findings of the study that the results of this research show that the direct taxes have a positive impact on public health expenditure. On the contrary, indirect taxes have a negative impact. It also confirms the importance of considering the direct tax based on high income quantiles to guarantee equality and access to health for all that contributes to health development. Practical implication, this article leads to the design of a new health system that will be useful for improving the health of Pakistan by presenting a solution to enhance health financing. financing. Social implications: improving health financing through the equality approach can provide public access to the health system, strengthen the positive effects of the health system on social economy. Highlights: it increases efficient highlights are the increase efficient health financing by integrating health coverage programs, implementing direct taxes based on income quantiles, improve health quality. Indirect tax policies will not positively contribute to health financing. And fourth is improving health financing efficiency decreases health inequality. Now coming to MCQs. MCQ number 1. In Taiwan, insurance companies are privately owned, but payments come from a government to which all citizens contribute. What type of healthcare model is this? Beverage model, Bismarck model, uninsured model, out-of-pocket model, national health insurance model?
A.
No, it is
A.
national health insurance model. E. Because here insurance companies, they are privately owned, but the sole payer is government. In beverage model, there is no insurance companies involved. MCQ number 2. Toby recently moved to Belgium and works for a marketing company. He is required to contribute to his insurance policy along with his employer. Despite having several pre-existing conditions, Toby's insurance must cover him. What type of model would be this? Beverage model, Bismarck, uninsured model, out-of-pocket model, national health insurance model?
A.
B is the right option. Third MCQ. In a country XYZ, as per suggestion of the government, a new policy is formulated for the country's health sector financing, which is based on taxing, and no out-of-pocket payment will be paid by the citizens. This is according to which of the following model of financing? Beverage model.
A.
Yes, A is the right option, beverage model. MCQ number 4. The beverage model is a healthcare system in which the government provides healthcare for all of its citizens through income tax payments. Which of the following statement about the beverage model is false? All citizens automatically receive insurance coverage through the government. The government runs hospital and clinics. The government decides how many doctors and specialties will be working at each hospital. Single payer health insurance is financed through taxes rather than premiums, so individuals don't need to pay anything to enroll.
D. No.
A is the right option. MCQ number 5. In Hong Kong, the healthcare financing model is funded using citizens' taxes. Health service is paid for exclusively by the government and is provided on a national scale, which citizens are never directly responsible for any of their medical bills. Which of the following model is followed there? Beverage model, Bismarck model, the uninsured model, national health insurance model, or out-of-pocket model?
D.
No, it is beverage model, A. MCQ number 6. The beverage model is named for its creator, an influential, inventive British reformer named William Belanger. Beverage. In this system, healthcare is provided for all citizens by the government. Which of the following is not true about it? It is referred to as a single payer national health service. People are not responsible for medical bills. It is funded by taxes. Most hospitals and clinics are owned by government. Hospitals and doctors are usually privately owned.
E.
Yes, E is the right option because they are usually owned by the government. MCQ number 7. The Bismarck model was named for the Prussian Chancellor Bismarck, who invented the welfare state as a part of unification of Germany in 19th century. Which of the following is not correct about this model? It is an insurance system, usually financed jointly by employers and employees through payroll deduction, bills paid by sickness funds. Hospitals and doctors are usually privately owned. Unemployed people also enjoy free health services. Any idea? Is the right option because unemployed people cannot be offered the health services. Only the employed people, they can enjoy free health services because it is funded by their payroll deductions. MCQ number 8. In rural regions of Africa, India, China, and South America, hundreds of millions of people go their whole lives without ever seeing a doctor. The rich get medical service while poor stay sick or die. Which model is discussed here? Beverage model, Bismarck model, national health insurance model, or out-of-pocket model?
Out of pocket model.
Yes, D is the right option. MCQ number 9. In Canada, the government funds healthcare services which are paid for through taxation, while the delivery of healthcare service is provided, however, mostly through private organizations. Their residents receive provincial insurance plans funded by both the federal government and provincial governments, which are used at mostly private clinics and hospitals. Which type of model is followed there? The Beveridge model, Bismarck model, uninsured model, the national health insurance model, and the out-of-pocket model.
D.
Yes, D is the right option, national health insurance model, because here we can see that the working model is the mixture of beverage model, as healthcare services are paid through the taxation of the public, and the delivery of healthcare services provided through private organizations, which is the characteristic feature of Bismarck model. So the mixture of these two models is a national health insurance model. MCQ number 10. Single payer healthcare refers to system in which there is one government agency paying for healthcare, but does not refer to a specific healthcare system model. Which of the following model is considered single payer system? Beverage and Bismarck, Beverage and out of pocket, Bismarck and out of pocket, Beverage and national health insurance model, and national health insurance model and Bismarck model.
B.
D is the right option. Beverage and national health insurance model. These two models are also known as single payer models, as government is the sole payer in these models. So this is the key of MCQs. This is the YouTube link of this presentation, and thank you.